10 seconds. 3, 2, 1. Go ahead, George.
Hello, everyone. I'm George Rocha, RWCE Live Chair, and today we have a very special section. We're going to talk about innovation in forestry and geography. And first, I'd like to thank our sponsor, Regeneron, Genitech, and Appels that support us. And now we're going to sweep for our president, Dr. Barry Kupperman, that is here. Thank you, Barry, for coming, and all yours.
Thank you, George, and thank you, Alan Franklin, for organizing this session. Again, I love these eLive series. Appreciate all the effort you do, George, with your committee to host people from all around the world, and look forward to an interesting discussion. Love the topics that have been selected as well, particularly today. So with that, I'd like to thank all the speakers, the sponsors, you, George, and Alan, and everyone involved. Thanks again. I turn it back over to you, or to Alan, I guess, now.
That's really great. Alan, thank you so much to organize such an international, innovative session, and I hope everything goes very well. Alan, all yours. Kick off.
Well, thank you so much, Barry and George. I'm really looking forward to this morning. Our panel is world class. We've got Dr. Barricall from Puerto Rico, Dr. Abrio, and Sosa Lockwood from the Dominican, and Dr. Mishev, all pretty much icons in vitrectomy surgery and visualization. I think one of the things that we're going to try to show is that intraoperative fluorescein is both helpful, and once you get it implemented, it's not that difficult to use. It's not esoteric. You can use it day to day in your operating room, and will help you with your surgical decision making. So our first presenter today is Dr. Gustavo Huning from Brazil. He puts on a beautiful meeting in the south of Brazil in June. He runs that. He's a great international speaker, and looking forward to hearing what he has to say about fluorescein angiography in the OR.
Hello, guys. Good morning to everyone. Alan, first of all, thank you for the invitation. Thanks for the RWC for hosting this webinar. I feel privileged. And as we've been, I would say, the same group preaching about 3DFA, and we want to show with this webinar, I believe, how important is this, how we are not using all the tools we have nowadays available, okay, to improve the treatment of our patients. Let me share my screen, and as Alan has asked me to, I will show you guys how we started with the 3DFA. In the beginning, wasn't that easy. The video quality wasn't what we have nowadays. So let's go forward. 1 second, I'll give it a play. I think it has already started. So I'll try to be brief. This is, I think it was my second or third video, and I have both screens here on purpose because we had the ingenuity, of course, what we have to use for the 3DFA. And on the left screen, I have the laser filter on, okay? And on the right screen, I took it off. So it is the same surgery. We have screens, videos, images from the same time. And we can compare the differences between having a filter and on the right side if we don't have a filter. What we can compare here is that on the right side, the image is more brighter, okay? And on the left side, we don't see it very well as we were supposed, or what we expected to see. But we can see more details, and I'm gonna show you in a few seconds. One of the first things that calls our attention, because when we are doing the 3DFA for people who are not used to do it, you have to lower the pressure of the eye. Otherwise, you have the VSS pressing the vessels, and it takes longer than a usual. While in a regular FA, it takes 15 seconds. Here, it takes almost a minute. But it is very interesting because we can see on real time how the fluorescein invades the vitreous cavity And that helped us a lot to understand the physiopathology, okay, of this disease. How did the diabetic retinopathy are, all the exudates are invading, and why the disease behaves the way it behaves, why cataract in these patients are usually subcapsular. So it gives us a new understanding of it, a real life, okay? Here you can see on the left side, I see more details of the microaneurysm, okay? While on the right side, this is still with the Ingenuity version 1.3. So images didn't have the detail we had before. And here, while we were studying this, and I like to say we play with it, I want to thank my two brothers who are also ophthalmologists, Artur and Afonso, because usually it was myself doing the surgeries, and my brothers were with the keyboard, sitting at my side and changing the colors. We were trying to discover which was the best color for each thing we were trying. The image is still granulated. We don't have a great field of view. But here you can see that there are some colors that shows us in a better way the macular edema, for example. And then we have other colors who are going to show us the new vessels, edema, or where we have an aneurysma. So it was, when we started it, I don't remember very well, Alan, you can correct me, it was 3 or 4 years ago. But some structures or some things that we wouldn't see properly before. I'm going to put this a little bit forward because it repeats itself a lot, just to show you, for me, the macular edema is better seen with this color here. It's a mix of green and orange, okay? And it differentiates the structures. How deep, which layer of the retina we can see. This also, if I had a intraoperatory OCT, would help a lot. Then let's go forward. Then we have the new version. This is already with the version 1.4, okay? And here we have a wider view of the retina. We can see also the fluorescein invading the vessels slowly. Usually when we have these cases where we have hemorrhages or bleeding, we have to increase the pressure, otherwise it will be a little bit difficult to operate, but it also holds the pace of the fluorescein. And one of the funny things I would say when we are doing 3DFA is that if you take too long to do the surgery, the fluorescein starts to block our view, okay? But we have nice images. For example, here we can see, okay, the erythrocytes inside the vessels. So this is one of the beauties of the 3DFA, that we can see now things we wouldn't see before. We can treat just the areas of the retina we are sick, so we can avoid over-treating, which is one of the big issues, in my opinion, when doing PRP in these cases, okay? But also we have to consider, like here in Brazil, the social economic thing, because these patients usually just have one chance to visit you. If you don't do a complete 360 PRP, they will develop or get worse and never get better. This is already with a new color, black and white, which in my opinion is one of the favorites. This is a vessel then we changed to the 3DFA, and this is with the new version. I think it was the first video. I was together with Alan, the version 1.5. We did it together, and here we can see how much the image has improved. So less granulation, it's more better quality, more details. So I think we are still walking slowly in it. The future here is very interesting. Thank you so much for your attention, guys. Let me stop sharing the screen.
Gustavo, this is great, and there are a couple things on the video and a couple points. The first one I just wanted to comment when you were talking about taking the pressure down so that the fluorescein could perfuse. It's really illuminating to see how poorly our patients perfuse their retina. Our diabetic patients perfuse their retina during surgery, and our non-diabetic patients, we typically see fluorescein come in much faster, but these sick diabetics, and we talk about having the bottle up, and I'm very guilty of this, to keep hemostasis during the surgery, and you feel like if you're actively aspirating, the pressure won't catch up and won't be high. But to get fluorescein to flow in, you really have to have the bottle relatively low and aspirate. And it just shows how tenuous the circulation is. And, you know, we know from Sohan Hayray, if you close the artery for an hour and a half, things don't work. And we're functionally closing it for 30 to 40 minutes sometimes during our surgeries.
Alan, on a related note, does it matter what the anesthesia that's used, and do you see variability? I mean, I try not to use general, but some cases need general anesthetic. Can you still do it this way? Or is the perfusion pressure dramatically lower? I know they keep the pressure lower on when there's general anesthesia.
That's a great question. Oftentimes we'll have poor flow in to the eye, even though we've brought the pressure down, and I'll ask the anesthetist if the case is whatever the case is what the blood pressure is, and they'll just say, oh, it's 88 over 48. And I'll say, well, they're not really perfusing their retina, so they're probably not perfusing their brain very much. And then we bump them up. So I think also from a neurologic safety standpoint, we can see that signal.
Can I add something on the anesthesia? Well, in case, I don't know if anybody uses it, but if it's used, the nitrous oxide, it will lead to vasodilatation in all the brain vessels, meaning that it will somehow compromise the conditions which we are trying to evaluate. So have that in mind.
Yes, and I guess one other comment, and I think we'll get back to this in a few of the other videos, is Gustavo, some of those videos where you were seeing the fluorescein leaking into the vitreous, those are areas of leakage and bleeding, and we're treating those more aggressively, and we think that's helpful as well. So that's something we can get back to on other presentations.
Absolutely, yes, because that's a big topic usually. Or, for example, if we want to discuss anti-VEGF, we are treating these patients and we don't see any leakage and we don't understand why they are not improving. Usually, now with the ultra-wide field images, we think it's just an ischemic peripheria, but this even if it isn't a new vessel, sometimes we have they're exudating, and that compromises the whole treatment. Because I always tell to my patients, it's more important to go to your endocrinologist to treat that systemic disease than coming into your ophthalmologist. Otherwise, we are losing time here.
Sure. Well, Gustavo, thank you very much for taking your time on Sunday morning. Enjoy the nice cool weather in southern Brazil.
I'll be here with you until then. Thank you.
Okay, well, thank you. Our next speaker is Dr. Absadi from Kuwait. He's been an early adopter. He's been a great colleague to work with. And he's going to have a presentation that shows fluorescein angiography isn't just for diabetic retinopathy. That's another theme that I want to show. It's going to help in a number of conditions. So, Khalid, if you'd like to show your video, that'd be great. And thanks for being with us today.
Sure. Thank you, everyone. Thank you, Alan, for your invitation, and thank you for the showing me or introducing fluorescein angiography for me, which is, I think, it really is very important in selected cases. I'm gonna specifically. Do you see my screen?
Yes.
Yes.
Okay. Specifically in cases of vascular occlusion, and I think having intraoperative fluorescein angiographies definitely will help us do important intraoperative decisions as how much surgery or how much dissection we can do. So let me share this case with you. I think it's a quite interesting case, and I think this is where intraoperative fluorescein angiography really stands out in such cases. Of course, diabetes is important, but I think in this case is where you want to make sure you reestablish the flow in the affected vein if you decide to do surgery for such cases. So I've selected really a textbook case where shithotomy.
Dr. Sabit, excuse me. We are not seeing your screen. Just the first slide. Please do it again.
Oh, can you see it? You don't see this?
We just see the first slide only.
We're seeing the general slide that says intraoperative FA with a picture of all the panelists. Okay,
I'm moving it forward. I don't know why it's not moving.
There it is. Now
yeah, that's good.
Also, you're not in presentation mode. We can see on the left all the slides. So can you move it to presentation mode? That's a better mode to be in. You can click on.
Can you see it now? No? It is now in presentation mode.
No, you need to share like you did it before the session.
Yeah, so I think you need to share
I have
screen.
presentation mode and share. Okay.
Yeah.
Let me do that. I don't know. I'm quite unlucky today with. Okay. So it should share now.
And share your entire screen.
Okay. Now?
Yeah, now go to presentation mode.
Okay, here we go. Presentation mode.
If you want to go using the thumbnails, okay, just not putting in the presentation mode and go ahead.
Okay, this is what I'm doing. I'm putting up presentation mode right now. This is the icon down the slide. Okay.
Yeah, go ahead using the icons. The thumbnails.
Yeah. Is that working yet?
No.
It's not advancing.
Okay.
Close your presentation mode. And go using.
Now it advanced. It advanced now.
Yeah.
Okay.
Perfect. Go ahead using this way.
Okay, I'll do it this way. I don't need to go. We don't want to waste our time. So I think where, as I mentioned, intraoperative fluorescein angiography stand out, particularly in these cases of vascular occlusion, which I think some of you would agree that surgery can be helpful in such cases. So this is a young lady who had no risk factor except she's hypertensive and presented of double vision for 2 months, vision down to 20/80. And as you can see, preoperative fluorescein angiography, I don't know if you see my mouse, showing a localized vascular occlusion at the crossing of the arteriovenous crossing in the upper macular branch. And after long discussion with the patient, I decided to do surgery. This is not my first surgery of vascular occlusion, but it was my first case of intraoperative fluorescein angiography. So let me show you the video of this case. How did I do it? I did fluorescein angiography intraoperatively, pre-shithotomy and after shithotomy. So first of all, as you can see here, of course, we have to use ingenuity in these cases because of the filter. And as you would expect, it's a young patient when I did lift the hyaloid. And if you can see here, this is the beginning of fluorescein, intraoperative fluorescein prior to shithotomy. I just want to highlight where we should look at here. I don't know if you see my mouse. It's here where the blockage. You can see the proximal to the occlusion and distal to the occlusion, where the flow is there is a flow, which is a good sign, and this is what you want to see, that there is a flow. It's not a 100% occlusion, and you can see the flow is not a uniform flow. You can even see how the blood flows slowly underneath the artery and then reconnects again. And then shithotomy, it's a simple procedure, and it's not very complicated. You just go in with a bent 25 gauge needle. And do you guys see the video?
Yes.
Okay. All right. So in shithotomy, what I do, I usually go either side of the crossing. so I don't inadvertently cut the artery. So once I do the sheathotomy, then I introduce a blunt spatula and extend the two cuttings together just to make sure I release the tension over the underlying vein. As you can see here, you don't need to be aggressive. Now you don't know how much you have to do. And I think this is where intraoperative fluorescein can help you to decide how much dissection you have to do. Basically, what you want to do is you want to reestablish the flow. So I repeated the fluorescein angiography. This is the second half. So I give a first half before sheathotomy and the second half of the syringe. And as you can see, almost normal blood flow over the vein. And as you can see here, the diameter of the vein is normal all the way, and the flow has been established. So this is really critical because I don't need to go again and I become more aggressive in doing the sheathotomy. I know that I have reopened the vein, and that's enough for this particular case. And then I know that this patient will do very well after surgery because of the very successful surgery. So actually, this was my fluoretina case of 2023 a few years ago, and you can see pre-sheathotomy and post-sheathotomy with re-establishment of the blood flow in this affected vein. One important point here, despite the fact that for diabetics, which I agree, we have to lower the intraocular pressure significantly, you don't need here to lower it significantly, because if you traumatize the artery, you wanna have a relatively higher intraocular pressure. So it's a totally different pathology. So I usually go between 25 to 30, and I will still see the fluorescein flowing in the vein. So this is just to show you at 3 months the pre and post-op test, the fluorescein and the OCT and the fundus camera of this case, which exceptionally, I think I was very happy that the patient did very well, and I think I was lucky also choosing the right case for the right indication. So again, thank you, Ellen, for introducing fluorescein angiography, which I believe it's a tremendous. I mean, there will be tremendous benefit from this technology. I hope it does improve to the extent that we don't need to inject a lot of fluorescein by enhancing the filter, so reducing even the risk further for such cases. And thank you again for the invitation.
Kelly, this was a beautiful, beautiful surgery. I have a question. Which cases do you choose to do surgery on or to inject with anti-VEGF?
Okay, it's a very good question. I really don't know the answer, but I think in a younger patient, first of all, you have to have a younger patient, and you have to document pre-operative fluorescein angiography that there is a flow in that vein. If this vein is being completely closed, there's no point for me doing surgery. So this perfect case, there is a partial blockage and younger patient, and the only risk factor she had is she's hypertensive. And the other thing, I would probably go sooner than 6 months, perhaps 3 months or even sooner, before you get permanent damage to the vein. I think that would enhance the success rate.
Just to follow up, I think that was a great question, Maria, great presentation. Do you initially do trials of anti-VEGF at the beginning as you see these patients? And those, for example, that have chronic, recurrent, or persistent macular edema, are those the ones that you selectively choose to then, after 6 months, let's say, address with surgery, or how do you do an empirical initiation with anti-VEGF?
I probably inject once and see how much they get improvement. If you are satisfied with the injection, I think probably it carries much less risk than doing a fairly aggressive. Probably people think it's more risky surgery. But if one injection does not help and the fluorescein angiography shows there is flow, I would probably do both. I do sheathotomy and inject simultaneously intraoperatively, just to maximize my odds of surgery.
Interesting. Thank you.
I have one question about side effects of francine, and the patient is lie down on the bed and his sedate or any kind of anesthesia. And how do you know that has some side effect of francine, and how to approach that?
I can comment on that because we are doing this like 3 to 4 years already. The patients are not in general anesthesia normally, and I wouldn't advise doing it without anesthesiologist beside you, because we had 2 cases in which one of the patients reported itching, general itching, meaning that something happens. So the anesthesiologist was quick with the steroids and everything was okay. The other patient was starting to coughing, so immediately we note that something is happening. So these are two cases which we had some complications, and the anesthesiologist was quite useful.
And it should not use general anesthesia on this procedure. It's more safe to operate only in sedation.
In general, I use general anesthesia only in children's. I mean, in elderly patients, they go well with intravenous sedation.
Good.
We also had exactly 2 cases like that. One itching, and the other one started to cough during the surgery. So what we do nowadays, we already inject it with steroids to avoid any other complication. It's easier, safer, because we don't have the structure in our hospital to do general anesthesia, and I think it's more simple. It's easier that way, and still the same way safe.
Yeah, here in the Dominican Republic, we started since the first case instilling steroids during surgery to prevent side effects. And we've never had anybody complain of itching or any other symptoms. Another complication that we've seen is that the catheter went through the vein of the patient, and the fluorescein stayed in the arm of the patient, and the patient ended up the surgery without the intraoperative and with all the fluorescein in the hand. So that's something to look for when you do the procedure and you don't get that the image that you want of hyperfluorescence of the vessels.
We actually also use, besides steroids, we give antiemetics. Because usually the feeling of vomiting is usually uncommon, so we do it anyway before using the fluorescein, for injecting fluorescein.
Dr. Habib, do you use in the intravenous anesthesia fentanyl? Because normally the vomiting is attributed to the fentanyl, at least in our experience.
No, usually we don't.
Mm-hmm.
No. Well, yeah, we do some general cases in the south of the U.S. I have patients that are very pain intolerant, as they describe, but we've not fortunately seen any issues under general, even with the laryngeal mask anesthetic, where the airway isn't completely protected. We've seen no nausea, so it's been pretty safe in our hands, and I think the thoughts of pre-treating with steroids and antiemetics are great. Since Dr. Habib is next, I'd like to introduce Dr. Habib from Cairo. He was an early adopter of this. He's really helped push our knowledge base forward on this technique, and he's a great surgeon and does a lot of pediatrics. I really look forward to his presentation today.
Yes, thank you, Alan. It's great to see you all again. So my presentation is actually about the pediatric case also. So this this is a pediatric vitreous hemorrhage case. Can you see my presentation?
Yes.
Okay, so that's a pediatric vitreous hemorrhage case. That's actually a peculiar one. She had a history she's a 6 months old baby girl. She was full term and she was completely normal until she was 3.5 months old. Her mother left her with a nanny, and when she came back, the baby was flaccid with low conscious level. When they got to the ER, they saw that she had an acute subdural hematoma. After that, the ophthalmic examination revealed retinal hemorrhages and vitreous hemorrhage, which spread to fill the whole vitreous over the following weeks, according to the report. She presented to me 3 months after this incident, or actually 2 months, with organized vitreous hemorrhage and no funded view. The labs for inflammation, vasculitis, such as CRP and infections were negative, and the coagulation profile was normal. So I had to go in. As you can see, that's a pretty tight space. The vitreous hemorrhage was organized already because it denoting the long-standing nature of the vitreous hemorrhage. So I had to go from the periphery so as not to injure anything important. And as you can see, there are also retinal hemorrhages and some ghost vessels, white sheep vessels. And when I saw that there was a subhyaloid hemorrhage with a very thick posterior hyaloid. So I was actually where it was retina until I saw the superior arcade, and I had to do a PVD in this circle that you can see on the posterior pole. And then when trimming this stalk emanating from the disc, I discovered it was bleeding actually. So sometimes in the pediatrics, in the pediatric cases, the retina could be pulled up and tented upwards. So I got worried that I actually cut part of the retina which was pulled upwards. So I decided to do an intraocular procedural angiography, and to my surprise, this was the picture. As you can see, extreme and generalized peripheral vascular occlusion with rounded endings, also involving the macula. And actually, this wasn't, I haven't seen this picture at all, even working with ROP and fevers. And as you can see, the stalk is actually fibrobacter perforation, which was emanating fluorescein stained blood. So I had to do PRP on this whole area and close the case. So that was the other eye, almost a mirror image. This rounded part of strongly attached vitreous around the posterior pole, and also this vascular occlusion with rounded ends. So I actually did the viral panel on the vitreous fluid, and all was negative. So my differential diagnosis, I was thinking first of pediatric vascular anomalies such as fever, PFV, and Norris disease. However, this was unlikely. Norris disease usually present with fractional detachment, and the fever and PFV is usually so far peripheral. Also vasculitis, which primarily caused both subdural hemorrhage and the retinal hemorrhage, but the systemic signs and the labs are all negative for inflammation and infections. And also comes the trauma, either accidental or abusive. So abusive head trauma can be in the form of repetitive shaking or soft object head trauma, which leaves no bruising, and also can cause acute subdural hemorrhage, which can be transmitted to the vitreous or to the eye by the optic nerve sheath, and also can cause extensive pressure on the central artery and cause central artery occlusion. And also there was reported cases of peripheral vascular occlusion in shaken baby syndrome or abusive head traumas. However, it was not this extensive. So this was the case, and I really don't. I'm not sure of the diagnosis. So what do you think about that? Thank you.
Well, I think this was a beautiful video. I believe that this could be related to the intracranial pressure, but even though in this kind of cases, it's very important to rule out, as you said, even though it's unlikely, fever and noise. So I think that genetic testing it's important in this case. I think this was a beautiful surgery. I would like to ask you, do you perform any weight-based adjustments of the fluorescein dose in pediatric patients?
Yeah, I usually give 1 cc. 1 cc instead of 3 or 4. So I was meaning to ask you about the. You said it is related to the head trauma. What do you mean by that? You mean the vasospasm that is caused with hypoxia and centrally, and also could be transmitted to the retina, or what do you mean?
Yeah, that's it. That's what I think. It could be related to intracranial pressure because of the subdural hematoma. I think that's the most probable cause, and because of the high pressure, the vascular occlusion, and then the vitreous hemorrhage, resembling it like a Terson syndrome. I think it was like very well managed, and I think that this is one of the beauties of the intraopa phase, that sometimes the ischemia that you see clinically does not correlate to the ischemia that you see in the intraopa phase. So using intraopa phase allows the surgeon to delineate these ischemic areas and to do a precise treatment. So very nice case.
And they couldn't do it before the surgery because of the vitreous hemorrhage, of course. But you were saying that the vasospasm could be caused could happen centrally, but also in the retina as a sequelae of the central vasospasm. Do you mean that?
I guess, sorry to interrupt, I guess it's the intracranial pressure which purely mechanically can close the retinal artery, not vasospasm.
The retinal artery, you mean?
That's correct. Yeah, that's correct.
Okay.
Ahmed, this is a beautiful surgery, but you also underscore the need. We should be using more intraoperative fluorescein even when we're doing exams under anesthesia in children, because children, you cannot do a fluorescein in the office or in babies. And I think this is an underused technique that, as you just showed in this case, would be extremely useful for diagnosis.
Yeah, that's a great comment, Maria. We have a case of a 3-year-old that was diagnosed. We diagnosed it with a cold disease, but she came with a prior diagnosis of a probable retinoblastoma. So we went in, we did a general anesthesia exam, and we did intraopa FA with a guarded light pipe, not going into the cavity and just putting a light in and doing the FA. And we eventually saw all the vascular abnormalities in the periphery. So it is very, very useful in pediatric patients.
So how do you do that, Nassim? What do you mean by guarded?
I can send you a picture. We just put like a stoppage on the light, and we just enter the tip of the endoprobe, and just so we don't go all over the place with the light. So we introduce a trocar, we put the light pipe with a stoppage wherever we want, with the length that we want, and we just do the test. And you
close it with a suture?
Yes. And in these cases, I try to eventually displace conjunctiva so we have less exposure of probable vitreous coming out of the sclerotomy.
You can also use the indirect. You can use it, with the indirect without having, do the fluorescein during the exam under anesthesia, use the blue filter, and then, not need to use the blue light in the indirect and not have to go in if you're worried about, tumors.
Yeah. Yeah. Perfect. Oh.
This has been a great discussion. I mean, it's a beautiful case, and it just shows you with the new technique, we're seeing new things, which is going to push everybody forward, push the science forward. So thank you so much, Ahmed. Dr. Mansour, also from Cairo, will be presenting next. He's been doing some great work on what light source to use. As we know, the next generation Alcon machine is not set up to do intraoperative FA. So those of us who are Unity users, we've got to try to figure out what we're going to do if we want to keep using intraoperative FA. So I'm going to turn things over to Dr. Mansour, and thank you for joining us.
Thank you, Dylan. My pleasure to see you all. I'll be sharing my screen now. So the presentation is a bit different. It's about talking about the intraoperative fluorescein, like we were talking very near me and Alan. Is it fancy or essential? Okay, so this is how it works. All with the white light, we have a blue filter, exciting filter. It goes to the fluorescence in the retinal blood vessel, and then the barrier filter we work on, and then a recording device at the leader. So this was my first intraoperative fluorescein case. When I did, it was just a diabetic case where I entered inside the young type 1 diabetes, 21 years. Where I entered the vitrectomy, it's okay, and now let's start this fancy technique. And then I let the fluorescein in, and wow, it's perfect, very good visualization. I can see the blood vessels, and you can see most of the microaneurysm in this part, the ischemic islands we can see. But actually here, it was just fancy. I can see the corpuscles. I was happy with this because I would finish it with always a PRP and nothing I gained from this surgery. Just a very good view, but what will happen next is the difference. After 2 weeks, I have this patient. She was a patient that did surgery outside for around 3 to 4 years, and she complains like she did have a very bad visual outcome after surgery. She's diabetic for just 2 years, and other eye has no diabetic change. So I went inside. She said she had a complicated surgery. I found very dense vitreous hemorrhage, as you can see in this part. And then after removing all this vitreous hemorrhage and doing everything, so now let's make use from this technique. So I started putting the fluorescein on again, and astonishing, there was no diabetic change, so this would go with my decision. This vitreous hemorrhage is not due to diabetes. So I went to thanks Lukan for this fluoroscopic vitrectomy. He was the first to show it. I like the fluoroscopic vitrectomy to show the vitreous in the periphery too much. And what happened when I removed all the vitreous, I found this part. Maybe this part was the cause of all these vitreous hemorrhages, maybe just a penetration from the anesthesia, because she reported second day post-operative she has this bad visualization, and this is the last eye. They told her not to do it, so this is the second time where the intraoperative fluorescein helped me. There's another case which has nothing more new, but something I did wrong in this case was doing the vitrectomy, fluoroscopic vitrectomy, but actually what I did wrong was injecting too much fluorescein inside the vitreous cavity from the start. But what helped me with this is that I have something called the modified autofluorescence filter. It's just light, not fluorescein, where I saw this. And after I removed all the vitreous, I let in the fluorescein again. As you can see, this part, this patient did laser before, and I used to do extensive laser in such cases. But now I go and see where the leaky area in cases of POVH or the post-operative vitreous cavity hemorrhage, and do limited laser for such cases, and they are performing very well. That's when it helped me a lot. And this was the new MVDs over the disc that was leaking fluorescein, and maybe the cause of this hemorrhage, and where I did the cautery and I conclude the case. Another change that happened to my surgery, and this I thank Alan for, it was after the fluoretina when we met. And he was performing a great surgery in the fluoretina, and I said, why not to do? I have been adopting 27 gauge for a long time now, around 6 months. But I will put the fluorescein from the start of surgery, and I will do the membranes like Alan did in the fluoretina. At first, it has very clear view, but I got something which is very good. In such flat membranes, you can differentiate these membranes from the underlying blood vessels that's going underneath these membranes. So you can dissect with very clear view in the intraoperative fluorescein, and you can remove everything. Again, this is the fluorescence mode that I use sometimes to see the membranes, but it will be shown very good in this part where I elevated the membrane and you can see the blood vessels of the retina underneath, so you can finish these membranes. This was my last case, and actually it's a question for all of you. It has been 1 week ago, and Nassim just raised the issue of the fluorescence that happened within the hand when you inject fluorescein in the hand. I have this case of MTM, and this past year, after doing the ILM and everything, this patient also was a diabetic patient. She has changed in the other eye, so I said, let's put fluorescein inside this retina and see what happened. But as you can see here, we started at 37 minutes in the port, and I checked for the hand if the fluorescein didn't go inside. Now we are 39, and then fluorescein didn't come in. I got the infusion to 10, and actually used the vacuum also to decrease the pressure, used many filters, but fluorescein didn't come to this blood vessels. It was very strange after, if you are doing laser and all the users here use the fluorescein, you are seeing the fluorescein has came to the vitreous cavity with the laser because it's giving this reflection, but there is no fluorescein in the blood vessel whatsoever after more than 15 minutes, which was very strange. I asked this patient, should go for a vascular patient, and they said she has extensive carotid ischemia, but I want to have your opinion about what happened in such case because I don't know. This is the last thing I'll be talking about, is trying to build the future like Dr. Allen was talking about, and this is how we go for the technique with the LED light. It's still not going to the maximum beneficial picture like we get from Dr. Habib, from Lukan, from my old technique, from Alan. But actually, the people say it's not safe. No, it's safe, and we're working with the R&D team now from maintaining the safety for this LED light. But the problem is the LED spectrum. It's a wide spectrum, and we're trying to work on narrowing this spectrum now to have a short wave lens to work with. And this was a case of postoperative vitreous cavity hemorrhage where I used this technique for. And as you can show here, it's a bit of granularity. The colors are not that great, but it's giving the job, and they can do the surgery for. And what happened here, I can found the leaking new vessel where I did the laser over the spot, just laser over this leaking new vessel, and left this patient, and she's achieving a vision of 6.9 now, or 0.5. So thank you, and I want your opinion about this case.
Yes, Ahmed, the case where the fluorescein was not coming in because the pressure was at 30, I've had that happen to me. And what happens is that if a lot of time passes before you lower the pressure, the fluorescein has already gone through the circulation multiple times, so you will not get such a thing. So what I did in that case was I lowered the pressure very low, like you did at 10, and then I re-injected 2 cc's of fluorescein to then see if it was a real, obstruction of his circulation, or just that my pressure was too high, and then if
This work we did. Yeah. This work we did. We re-injected at 10 and with the vacuum on, and still we didn't have the fluorescein inside the blood vessels.
So then you know that the carotids are the problem. Yes.
Mm-hmm. Yeah, I've had that same issue. I had it this week. We were working with an anesthetist, and they pushed the fluorescein in very slowly over a minute or two, and same thing. It just gets diluted in the circulation. They've got the anesthesia people have to push it in fairly quickly.
Okay, so if it's pushed very slowly, it may be the cause that it will be diluted and not work. Because in this case, I had a new technician in the room who was injecting this fluorescein. Maybe this is the cause, actually, but the extensive ischemia on the carotid made me think about it, but it will not be that severe that we did not show the fluorescein at the blood vessels at all.
So, Alan, is the injection speed roughly should it be the same as in regular office-based fluorescein angiogram, slower, faster? Over how many seconds do you inject, and how many? Is it 2 cc's, or how many cc's are you injecting?
We're injecting 2.5, and in the clinic we'll inject 5 cc's total, but in the operating room we'll do 2.5. Mm-hmm. Especially if we do it earlier in the case to help us with the peel, and then we do another 2.5 later. One of the things that that second 2.5 shows is it shows a lot of hot spots of fluorescein leaking into the vitreous that we typically wouldn't see just with the standard video feed. And then we'll occasionally see occult retinal neovascularization. Maria and Nasim have seen it also, and Joaquin has worked with them. And our post-op vitreous hemorrhage rate is been significantly lowered since we've been treating it. It's been pretty striking, and so we're working on a paper. I think but it's my turn to catch up on some data, some demographic data. But hopefully we'll have that paper submitted in the next month.
And is the fluorescein injected over 15 seconds or so?
Yes.
30 seconds?
Yes.
What's
It's injected over about 15 seconds.
Thank you.
15 seconds.
So I want to make a comment on the speed of injection. I think this is critical. We can do a standard injections in adults, but in pediatric patients, we have to be a little bit more careful with that. We had a patient with ROP that we entered to surgery, and we did intra-op FA, and the anesthesia was injecting the dye, and she did it pretty quick, and it just blew through all the neovessels, and fluorescein was everywhere. So with kids, we have to be a little bit more careful because it's gonna get to the eye a lot more rapidly.
You say this is ROP case. Was this in a preemie, or was this a more adult, a more mature ROP case?
Yeah, it was a preemie. I can't remember now how many months old the baby was, but I think in general, kids under 3-4 years, we have to be a little bit more careful because it's going to get a lot faster.
And use very little.
I was going to ask, that question.
A smaller, a more diluted concentration, a little bit less volume.
Thank you.
Before moving forward, I would like to ask Ahmed, what concentration are you currently using for your fluoroscopic vitrectomies? Because I've been trying this technique. I started with 10%, which is a lot, and then I've been moving forward to less concentrations, even 1% or 0.1%, because the fluorescein keeps recirculating in the vitreous cavity. So what concentration are you currently using for your cases?
0.1% is enough, and I dilute it till it's very, very light yellow, very, very light yellow, because if you did more than this, you will face the same situation I faced in this case. It will be staining everything, and it will be very difficult.
Dr. Mishev, same thing for you. I mean, Dr. Mishev is really...
I took this from Mishev, actually.
Since I sort of introduced this technique, let me say a few words about it. If you put too much fluorescein inside, you will spend a lifetime cleaning the vitreous. So anything which is less than 0.1% or it is light green, it's doable. If you want to do it fluoroscopic, you can go even lower because you will have excitation. But if you are in the light green spectrum of the solution, you can do it in an analog view with a regular, or not regular, but digital filter plus regular xenon light without excitation. So there are two routes of doing fluoroscopic vitrectomy. The key point is to lose as low as possible concentration, otherwise it is a nightmare.
Well, I think we'll move forward to Dr. Martinez, who's has done some beautiful videos on intraoperative fluorescein, also from the Dominican. So I look forward to your case.
Thank you, Alan, for your presentation, and also I feel very grateful to be here sharing this panel with you guys. So I bring you a simple case compared to the others one that we've seen today, but it also shows the versatility of the intraop FA in also these kind of cases. So moving on, I have named this case From Mystery to Management, and it's about a 60-year-old Dominican female presented with a 3-day history of sudden visual loss upon waking. She had no prior episodes of visual disturbance, and as per the findings, she showed headache and lightheadedness for at least 2 weeks with no improvement, raising suspicion of undiagnosed hypertension. BP recorded during visit was 180/90. She had no history of ocular trauma nor eye surgery, and denied also diabetes or any blood disorders. Best corrected VA was 20/40 in the right eye due to cataract and had movement in the left. In the right eye, we see the white ring in vitreous, and there was also mild vascular tortuosity of the retinal vessels with some AV crossings, while all other findings were unremarkable. On the left, a dense VH blocked a clear view of the fundus. It appeared recent with mobile clots and fresh blood in the mid and posterior vitreous. B-scan ultrasound, it showed mobile vitreous opacities consistent with hemorrhage. Although there were no signs of retinal detachment nor tears, there was considerable thickening of the posterior pole. It raised suspicion of intraretinal hemorrhage or even a possible subretinal component. So surgical management of the left eye started with a corvetrectomy to clear all these dense vitreous hemorrhage. Fortunately, the media began to clear little by little, and we were able to get a good view of the posterior pole. So now with that improved visualization, we spotted in the mid-segment of the infratemporal vascular arcade a lesion surrounded by intraretinal hemorrhage consistent with macroaneurysm. We then performed intraopera phase to check for any angiographic signs such as secondary leakage, and these show focal hyperfluorescent lesion along a branch retinal artery consistent with a ramp, with only minimal leakage even after lowering the pressure. So before moving on, we also took advantage of the FA to look at the periphery for any other possible bleeding sources or even occlusive changes. So once everything was assessed, we carried out a controlled continuous laser photocoagulation after proper titration and power adjustment. The aim of this was basically to sclerose the macroaneurysm and try to avoid any edema secondary to the lesion. So on day 1 post-op, there was no vitreous hemorrhage, and both the patient and I were also pleased with this result. The OCT of the left eye showed no subretinal residue or foveal thickening. The RAM appeared to be of the anterior type, which is generally the less harmful to vision, and the outer retina and ellipsoid zone were also intact in all OCT cross-sections. At 3 months post-op, the VA remained stable with only some exudates surrounding the affected artery. Late phase FA showed normal transit with no angiographic abnormalities, and arterial flow in the treated vessel remained unchanged after laser treatment. This was the result, and this is the case I brought today to discuss. Thank you.
Well, it's a beautiful case. Again, it shows the versatility of the technique. I've actually done some of these where we laser under the fluorescein because you can see the full extent of the RAMA, and I think these are really helpful, and it's a beautiful case. I think we're running out of time here, so I'm gonna hand off to George, but I want to truly thank all the presenters and the panelists for their time. I think that this has been a great hour of education. I've learned a lot, and thank you again.
Wow, that's really innovating session. I learned a lot with all of you, and was incredible. Beautiful case, and a lot of to think in the future of the intraoperative fluorescein that help us in diagnosis or guide treatment. And whatever, we're gonna learn more and more and have better filters, better cameras that helps us to see more and this dynamic. You can really feel during your surgery the best what we can do for our patients. Alan, thank you so much to put it together. It's a really international panel with all continents and very skilled colleagues. Everybody brings us a lot of insights. And also I'd like to thank our sponsor, Regeneron, Genentech, and Apellis. And thank you all for staying with us and teach so much and give us so much pleasure in this hour. See you soon and have a great Sunday, everyone.
Thanks, everyone. That was amazing.
Thank you.
That was super cool.
Thank you.
Here.
Thank you.
Sorry.